So this is going to be our narrated PowerPoint for the trauma overview chapter. Pretty much just kind of get you into the role of traumatic injuries and not specifically the different types of injuries to the bodies, as those will be covered in your chapters. But like I said, this is just going to be our overview. So for people younger than 44, traumatic injuries are the leading cause of death in the United States. And traumatic injuries occur as a result of physical forces that are applied to the body. So we get hit, we fall, we get shot. Those are considered trauma, whereas medical emergencies are emergencies that result from some type of illness or medical condition. So evaluation of your mechanism of injury for a trauma patient is going to provide you with an index of suspicion for different types of injuries. So an index of suspicion such as if I were to respond to a motor vehicle collision and I saw that there was deformity underneath the steering wheel to the dash, that would lead me to believe that I had an index of suspicion for injuries to the lower extremities like the femurs or the pelvis. So traumatic injury occurs when the body's tissues are exposed to energy levels beyond their tolerance. Basically, when something is swung at us that our body cannot tolerate, traumatic injury takes place. And mechanism of injury that we just mentioned, it actually describes the forces or the energy transmission that's actually acting on the body to cause that injury. So you want to look at, the different types of force, and we'll get into the physics of it here. So three concepts of the energy that we're talking about would be potential energy, kinetic energy, and energy of work. Now, nobody expects you to be able to regurgitate this information, but you need to have a working knowledge of it so you can apply it in a practical manner. So work is actually force acting over a distance. Okay, so forces that bend and pull or compress tissues in the body beyond what they can normally handle result in the work that causes that injury. And kinetic energy is the energy of a moving object. So this is anytime we don't think about, a train going down a track as being energy. We just think about it as a train going down a track. But there's lots of things that are involved there. The mass of the train versus the velocity or the speed at which it's traveling. So kinetic energy, the actual equation for it is 1/2 the mass times velocity squared. So, and then we have potential energy, which is usually the product of, it's usually associated with energy from falling objects, because potential energy is we take the weight of an object plus, how far it's going to fall, and, we factor in gravity and that type of thing in order to determine the force behind it. So mechanism of injury profiles. So we have non-significant MOIs, or mechanisms of injury, and those are injuries to an isolated body part or maybe a fall without a loss of consciousness. But then we have significant MOIs, and these are injuries that involve more than one body system, which known as multisystem trauma. We'll be covering that a little bit later. And we're talking about falls from heights that can cause significant injury. Motor vehicle and motorcycle crashes, cars versus pedestrians on bicycles or motorcycles, and then we have gunshot wounds and stabbings as well. All of these are significant mechanisms of injury. So trauma is actually split into two categories. You have blunt and penetrating trauma. Traumatic injuries can either be penetrate into the body itself, or they can exert a force on the outside of the body without breaking the skin. So when we exert a force on the outside of the body without breaking the skin, that is known as a blunt trauma. Whereas actually when the exterior surface of the body is compromised and the internal part of the body is exposed to the outside, that is what we call penetrating trauma. But either type can occur from a variety of different types of mechanisms of injury. So blunt trauma. Blunt trauma results from an object making contact with the body. Things like motor vehicle crashes and falls are really common, whereas the motor vehicle crashes into a thing and then the body crashes into the vehicle itself. We want to make sure that we're alert to skin discoloration and things like that, because they may be maybe pain in a certain site. They may be the only indicator of blunt trauma. But we want to make sure that we maintain a high index of suspicion for hidden injuries. So that's where it's important for us to know our anatomy and physiology, because if a body is struck in a specific area, then we know by knowing what organs are located in that area of the body, we can have an index of suspicion of the types of injuries that may have occurred. So there's actually 3 crashes or 3 collisions in every motor vehicle collision. Typically, you have the car that strikes another thing. That could be a bridge abutment or another car or a tree or whatever. And by looking at the vehicle itself and what kind of damage there is to it, we can determine the force that was exerted. Obviously, a slower moving vehicle is not going to have nearly as much damage typically as a vehicle that was traveling at a higher rate of speed when it impacted a stationary object, and that type of thing. So collision number 1 is going to be the vehicle against whatever the object is. Then we're going to have collision number 2, and that's going to be the passenger actually crashing into the interior of the vehicle. And that doesn't matter if they're hitting an airbag, a seat belt, a steering wheel, the windshield, or whatever. So we have the vehicle crashing into an object, and then we have the body traveling forward and crashing into the vehicle itself. And then we'll move on, and we have the internal organs that are crashing against the solid structures of the body. So think of it this way. If your vehicle is traveling 60 miles an hour and it crashes into a bridge, your vehicle goes from 60 miles an hour to 0 miles an hour immediately. But your body continues to travel at 60 miles an hour until it meets the interior of the vehicle. Once it meets the interior of the vehicle, the exterior portion of your body goes from 60 miles an hour to 0 miles an hour. But the organs inside your body continue to travel at 60 miles an hour until they impact with the interior cavities of your body, such as your rib cage or the inside of your skull. You can look over here, and you can look over here on your PowerPoint presentation. You can see that an example of that 3rd collision is what's known as a coup contre coup, and that's where the brain continues forward inside the skull and actually makes impact with the frontal bone and damages the brain itself, and then by stretching in the rear or even compressing and bouncing back, injury to the rear of the brain happens as well. It's a very, very serious injury. So we'll find anytime you consider all these following to be significant mechanisms of injury. Anytime there's a death in a vehicle, anytime there's a fatality, we automatically consider every occupant in that vehicle major trauma, because it took some type of significant MOI to cause a death, and everyone in that vehicle was potentially subjected to something very similar. Anytime there's severe deformity of a vehicle or actual compartment intrusion, which means the interior compartment has been compressed in some way from some direction, anytime that's present, we consider that to be significant. If there's severe damage from the rear of a vehicle, or anytime there's a rotation injury impact involved, because lots of different forces can be subjected upon the body in rotational injuries, or in rotational impacts, I'm sorry. And also, obviously, whenever there's an ejection from the vehicle, lots of things have to be considered, such as how far the patient was ejected and what surface they came in contact with, and those type things. So, frontal crashes. First thing we're going to do is we're going to evaluate the restraint system. Was the patient wearing their seatbelt? Did airbags deploy? Seatbelts and airbags are effective in preventing that second collision inside a motor vehicle, but it doesn't mean that they prevent all injuries. Seatbelts can actually decrease the severity of the third collision, because the body is not allowed to travel at a rate of speed for a prolonged period of time during the second collision. And remember, the second collision is the body striking the inside of the vehicle, where the third collision is the organ striking the inside of the body. And airbags can decrease the severity of the deceleration, but it doesn't mean that you can't still have injuries to the extremities and that type of thing. So, like I said, despite airbag injuries, you can still have extremity injuries. There can still be injuries to internal organs. And children shorter than 4'9" should always ride in the rear seat. And remember that the airbag, if it didn't inflate during the accident or whatever, it can actually deploy during extrication. So you want to be extra cautious of that, because an airbag going off can be fatal to a responder that's not paying attention to it. And also, supplemental restraint systems can actually cause harm themselves. They can cause hip dislocations if the seatbelts are worn too low, or internal injuries to the abdomen and chest can occur when they're worn too high. And in children and older patients, you can have lumbar and spinal fractures no matter how your seatbelt's worn, just because of the type of impact. So once again, remember that just because a patient was wearing their seatbelt doesn't mean that the mechanism of injury was not significant. So you want to look for contact points between the patient and the vehicle as you do that quick evaluation for the interior of the vehicle. Look at places like, if there's a shattered windshield, or do you see deformity to a steering wheel, those type things. So where the patient might have actually come in contact with the vehicle, that underneath the dash that a lot of people forget about was their deformity where the knees struck that dash, as people went down and under. Because by finding these specific things, we can focus our assessment a little bit more on areas of the body that may have been affected by the trauma. Rear end crashes are a lot more serious than a lot of people think. Sure, we think about people getting struck in the rear end, but we don't think about the whiplash style injury, how serious that can be. So an appropriately placed headrest, we note that in all our newer cars, the headrest actually leans forward. And I've heard a lot of people actually complain about that their head touches it constantly. But that's okay, because it's there to provide, if you're in a rear end collision, it's there to provide some support to the back of your head, so your head does not hyperextend, and those forces, those shearing forces, can reduce those to your cervical spine. So as the body is propelled forward from a rear end collision, the head and neck are basically left behind. So that's where the headrest comes into play. And you can have actually an acceleration type injury to the brain. Patients in the back seat are actually more susceptible. They have a higher incidence of injuries to the thoracic and lumbar spine, because in most cases, or in a lot of cases, people in the back seat are only wearing lap belts and not full shoulder belts like those up front. We also have lateral crashes. Lateral crashes are actually associated with a lot of deaths or a lot of fatalities in motor vehicle crashes because of the point of impact. Any kind of vehicle that's struck from the side usually is struck above its center of gravity, which means that the vehicle begins to rock away from that side of the impact. This results in the passenger sustaining lateral whiplash. So remember, in the rear impact, where the body was thrown forward and the head and neck were left behind, in a lateral, the body is struck from the side, and so the head and neck are still left behind, but they're moved to the side instead. So if there's substantial intrusion to the passenger compartment, make sure that you suspect injuries to the side of the chest and the abdomen directed to the side of the impact. Possible fractures of the lower extremities, maybe in the pelvis and the ribs, and we know that femur fractures and pelvic fractures can be life-threatening, and organ damage from that third collision that we've discussed already a couple of times. The rollover crashes are probably the most difficult to determine as far as mechanism of injury. We know that it took significant force to make a vehicle roll over, but any vehicle with a high center of gravity is more prone to a rollover than a vehicle with a lower center of gravity. Injuries are going to depend on whether the patient was restrained, but also we don't know about flying debris inside the car. And when we have a rollover, we look at the exterior of the vehicle, we see so many contacts with different places, it's impossible to know where the majority of the force was concentrated in a lot of places. So basically, we have to be have a high index of suspicion for everything from rear, lateral, rotational, all the different impacts to the person in a rollover collision. Also, patients can be ejected in rollovers, and so then we have either fully or partially, and then we have to take into consideration the speed, the distance, the surface that they impacted with, etc. Moving along, rotational crashes that I just mentioned, they are conceptually similar to rollovers in that lots of different moving parts inside the vehicle. The rotational spin of the vehicle puts different forces on the body that the body's not used to, and you might provide opportunities for the vehicle to strike additional objects such as other vehicles or utility poles or other stationary objects. Car versus pedestrian, that's one we always dread. Injuries in a lot of cases are often graphic. They're visually apparent, but there can be also serious unseen injuries. Make sure that you determine the speed of the vehicle, if the patient was actually thrown through the air and at what distance that patient was thrown, what surface the patient landed on, was the patient struck and pulled underneath the vehicle. Other things you might want to evaluate: was there any damage to what kind of structural damage to the vehicle was done? Because obviously that indicates additional force. And anytime we have a suspicion for a significant mechanism of injury, ALS backup should always be got en route, and that's part of that initial scene size up where we have scene safety, PPE, number of patients, our mechanism of injury versus nature of illness, and then do we need additional resources? We could definitely put ALS in that group right there. Cars versus bicycles. Once again, very similar to cars versus pedestrians. We want to make sure that we evaluate damage to the bicycle and where it's positioned, and get that same information about the patient being thrown and so forth. And also, if the patient was wearing a helmet, we might want to inspect that helmet for damage. We would always presume in any trauma that the patient has sustained some kind of injury to the spinal column. We want to make sure that we maintain C-spine. You know, in your from your checkoffs in class, whenever you're doing any type of trauma, any type of assessment or whatnot, we always consider C-spine if there's a possibility that trauma was involved. And so that spinal stabilization should be initiated immediately, and it's got to be maintained all the way throughout the encounter until some type of permanent mobilization can be put in place. In cars versus motorcycles, there's usually a little bit of additional protection to the patient, but that doesn't mean that they can't be significantly injured. They do, in most cases, they're required to wear a helmet, but that doesn't really protect against any kind of cervical spine injury. Just basically, that's an impact injury to the skull itself, or preventative to the skull itself. You might have leather or some type of abrasion-resistant clothing, and it will protect against road abrasion to a certain degree, but it doesn't do anything for blunt trauma and that type of thing. And then again, there can be boots or whatever to protect the feet and potentially the lower extremities, depending on how high they ride. But when you're looking at that scene, you're looking at deformity to the motorcycle, which side had the most damage, how long was the skid on the road, was there any deformity to stationary objects or other vehicles, and look at the helmet specifically for damage and look at how significant that damage was and exactly where on the helmet that damage was located. And there are 4 types of typical motorcycle crashes. There's the head-on crash, where the motorcycle strikes another object and it stops its forward motion, but the rider in most cases will be thrown and continued until it's stopped by an outside force, such as a road or a tree or that type of thing, another vehicle. There's an angular crash, where the motorcycle strikes at an angle and you end up with crush injuries because of the rider being crushed between the motorcycle and whatever object he was striking. Also, we have ejection, where that rider travels at a high speed until stopped by a stationary object that we just mentioned. And then we have the controlled crash, where a rider may see a crash happening, and it's called where they lay the bike down, where they'll lay the bike down and let that bike travel on ahead of them and absorb the largest portion of the impact, while the rider stays a little bit farther behind and the impact is less significant. Falls are very popular, obviously, in the pre-hospital world. And the injury potential of a fall is directly related to the height that the person fell from and what surface they landed on. So the greater the height of the fall, obviously the greater the potential for injury. This is a good thing to make note of, is any fall from greater than 20 feet or more is considered significant. Okay, so if you fall from 20 feet on whatever, it's considered a significant mechanism of injury, and all the precautions are going to be taken for a possible major traumatic event. And internal injuries pose the greatest threat to life, although lots of skeletal injuries can take place. For patients who fall and actually land on their feet, okay, that may be great as far as them absorbing a lot of impact and not having as much damage to internal organs. But we have to take into consideration the damage that, or the force that is projected along the spinal column. So we can look at everything from compression fractures to pelvic fractures, injuries to the lower extremities, all the way up to to C-spine with micro fractures in the vertebral column. So anytime you're evaluating a fall, things to take into account would be obviously the height of the fall. We've mentioned already the type of surface struck. Big difference in falling from 20 feet into a freshly plowed field than there is onto a concrete driveway. And then we look at the part of the body that hit first and kind of follow the path of that energy displacement along to see if we can determine, what body parts and systems might have been involved. So we talked about blunt trauma, and we talked about that there were two types, blunt and penetrating. So we'll go into the penetrating trauma now a little bit. Penetrating trauma is the second leading cause of traumatic death in the United States after blunt trauma, because penetrating trauma typically involves something entering the body, breaking the surface of the body. And there's low energy penetrating trauma, and that can be caused by someone falling onto post and becoming impaled, or could be intentional by someone being stabbed with a knife or some type of other weapon or whatever. But those are low energy penetrating traumas. It's good to know. And with low energy penetrations, in the actual injuries are typically caused by the sharp edges or sharp or jagged edges of the object as it's moving through the body. Okay, so those injuries are going to be close to the object's path. Now, if someone has stabbed someone deliberately and moved the knife around, twisted it, or whatever, you can actually cause obviously more damage inside the body than the external wound would suggest, where we see just one external stab wound. You think about all the places the blade of that knife could have reached inside the body, and all those tissues and organs could have been involved. But these are low energy penetrations. Keep that in mind. In medium and high velocity, we're talking about speed, okay? And it's usually the path of the projectile that we're talking about. And we're usually talking about a bullet, okay? And it might not be easy to predict what that path is, because the bullet may flatten out, or it may tumble, or it actually could even ricochet within the body before it exits. Like a 22 bullet is small, it's fast, and it literally, when it hits a bone, it travels in a different direction until it hits another bone. And so you may see a 22 enter the body in, I don't know, the upper left chest and enter the or exit in the lower right abdomen, because we have lots of different things for it to bounce off of. But the definition of trajectory is the path the projectile takes. So the path that bullet takes is its trajectory. And remember, fragmentation can increase damage. Fragmentation is when that bullet were to break apart. If it were to break apart, then obviously we would have multiple trajectories as the pieces traveled in different directions, causing significantly more damage. And then we have cavitation. And cavitation results from rapid changes in tissue and fluid pressure that occur within the passage of the projectile. So basically, we have a pressure wave. We have temporary cavitation and permanent cavitation. Temporary cavitation is that pressure wave as a bullet is traveling forward, it's pushing air, it has force, and then you have the force of the impact, and it creates this pressure wave. And you can see in your diagram here where you have the temporary cavity as the bullet travels through, and that temporary cavitation can cause all kinds of damage to surrounding organs and that type of thing. It can tear vessels, lacerate solid organs, cause hollow organs to rupture and leak their contents into the surrounding cavities. But then once that temporary cavity reforms or goes back to its normal size, you still have your permanent cavity that goes along the pathway, the specific pathway of the bullet, and this is where we can have lots of hemorrhage and that type thing involved. So the relationship between the distance and severity of injury basically depends on the kind of weapon we're using. The farther away, the slower the bullet's going to be when it reaches its target. We have air resistance, right? Air resistance, often referred to as drag. It slows the bullet as it's approaching its target, so it can decrease the depth of penetration, and it can decrease the energy of the projectile, and it can reduce the damage of tissue. So that's kind of common sense, right? If you get shot from 2 feet away or from 200 feet away, you would expect less damage at 200 feet away if the same type of projectile were being used in both. Okay, and the area that's damaged by a medium or high velocity projectile is usually many times larger than the projectile itself because of that pressure wave. That's why exit wounds are often larger than entrance wounds. But also keep in mind that in the field, we don't refer to them as entrance and exit wounds because we are not ballistic experts. We may find out that we have a patient who has been shot with whatever type of firearm, and we have a small hole on one side and a big hole on the other side, but we would just report that as the patient had a wound to both sides. And of course, we would record the size of those, but we would not refer to it as an exit wound. Here's a nice chart for penetrating trauma. You can read this at your leisure. It covers blunt or penetrating trauma to different parts of the body, from the neck to the chest or whatever, and the signs and symptoms associated with it and what your index of suspicion would be. This is located, you can pause here, or you can review it in the standard PowerPoint that's non-narrated. So we'll talk for a minute about blast injuries. We mostly see those in military conflict, which obviously in the pre-hospital setting we're not typically dealing with, but it's also seen in mines and shipyards and chemical plants. And we hear about terrorist activities all the time. So we can have blast injuries from a multitude of places. This figure right here shows the 4 mechanisms of the blast injury that we're going to cover. You can see we have primary, secondary, tertiary, and quaternary blast radius as it goes along. And we'll talk about each one of those. That primary blast injury is actually the pressure wave, the damage that's done by the blast itself to the body. Then that secondary circle that we saw, that's the flying debris. Okay, so we have the primary injury, which is the pressure wave from the blast, the secondary injury, which is the debris projectiles flying through the air. We have tertiary, which is the person has been thrown and whatever they're striking, whatever surface. And then last, we have a quaternary or miscellaneous, and this could be anything from burns to crush injury to inhaling toxic gases and having respiratory issues. But most patients that will survive any type of blast injury are going to have some kind of combination of the 4. Organs that contain air or hollow organs, they're more susceptible to pressure changes, and so obviously they'll be more sensitive to blast injuries as they can explode. You might find organs in the gastro and urinary tract, the lungs, the middle ear, things like this that pressure wave can cause them to rupture. And pulmonary blast injuries are identified as pulmonary trauma that results from short-range exposure. That's big words for saying that our lungs can explode or be damaged. We have barotrauma from a pressure wave. Pneumothorax, air outside the lung, inside the chest cavity, is a common injury. It might require some decompression from an ALS level. And another thing we might have is an arterial embolism, and this is definitely life-threatening, and it can produce anything from vision disturbances to behavioral changes, altered levels of consciousness, and you can have a variety of neurologic symptoms from paralysis and weakness to one side of the body and those type of things. And so solid organs are those organs that are, well, not hollow, right? They're more dense tissue, your kidneys, your liver, things like that, but they're not as susceptible to a pressure wave, but remember they can be lacerated due to blunt trauma from that secondary impact and the tertiary impact when you're striking other objects. And we know that you can also have extremity injuries from like traumatic amputations, injuries to the eyes, things like that. They're common as well. So we talked about at the very beginning of all this, multi-system trauma, and that we would mention it later on. Well, now it's time to mention it. Multi-system trauma is just that. It is trauma that involves more than one body system. You might have head trauma and spinal trauma together. You might have injuries to the chest and the abdomen. Note that we have in our chest, we have our cardiovascular system, we have our respiratory system. In our abdominal cavity, we have major organs like our liver, our spleen, our pancreas, our digestive tract, urinary tract, huge vessels in our body that can be included. So anytime you suspect multi-system trauma, you're going to alert medical control immediately, and we're going to transport as rapidly as possible, because multi-system trauma patients don't have a high level or percentage of survivability. So when we're treating multi-system trauma, or we're treating any traumatic injury, your main priority is going to be your safety, and in order, your personal safety, then the safety of your crew, then the safety of your patient, and then the safety of any collateral people around, okay? And in that order. You'll need to determine the need for additional personnel or possibly even specialized equipment and evaluate that mechanism of injury. And we do that by taking all those forces into consideration and as to what has actually happened to our patient. We're going to initially identify and manage all life threats as quickly as possible. We're going to focus our care on hemorrhage control, because that's our highest priority. The reason being is because we've got to keep blood in for blood to keep going around and around and carrying oxygen. As soon as we get hemorrhage under control, we're going to assess and manage the airway. And this could be anything from us having to put someone on a non-rebreather to actually having to breathe for someone with a bag valve mask. And the whole time we're doing that, we're going to make sure that we try to have our appropriate spinal restriction in place, keeping that manual C-spine and with a cervical collar. Then we'll ensure that that all shock is treated, and we treat shock by lay them down, wrap them up, elevate their feet if necessary, and then if required or called indicated by protocol, we would maybe potentially follow up with some spinal mobilization. We're going to transport to definitive care, because remember that any trauma victims, the only way to heal is with cold, hard steel. They need to get to definitive surgical intervention in order for them to have the potential for survival. So our on-scene time should always be 10 minutes or less, okay? Always 10 minutes or less on any trauma scene. And we're going to, while we're doing our secondary assessment after we've left the scene, we will try to obtain a sample history, if at all possible, and complete our secondary assessment. Once again, if we hadn't already, we would consider ALS intercept, or potentially even air medical transportation. So we know how to assess a patient. We've covered it numerous times, but remember that whenever we're doing a trauma assessment on someone who has experienced a significant mechanism of injury, performing that physical examination rapidly and getting them out, and then doing that head to toe en route to the hospital is how we're going to want to deal with that. So some specific injuries. If there's injuries to the head, remember that there could be disability that we don't see immediately. Bleeding or swelling inside the skull can be life-threatening, and we might not see that initially. May not have any obvious signs until even hours or potentially days after the injury. But we're going to continually re-examine our patient's neurostatus while we're en route to the hospital. Injuries to the neck and throat. Obviously, we want to remember that airway problems can result very quickly. It's not something that, once we check it initially, we don't have to worry about anymore. It's constantly developing. Make sure that your physical examination includes looking for DCAP BTLS, and we'll remember that stands for deformities, contusions, abrasions, punctures or penetrations, burns, tenderness, lacerations, swelling. And remember that swelling to this area, we also look for jugular vein distension in the neck, and that swelling in the neck can prevent blood flow to the brain and cause issues with the central nervous system. Any kind of penetrating injury to the neck can cause an air embolism. Air may actually enter the vascular space or whatever. And crushing injuries to the upper part of the neck can cause the airway to collapse. And obviously, once we have a collapsed airway, air doesn't go in and out, and that's a huge problem. Injuries to the chest can include injuries to the heart, lungs, the great vessels, your superior inferior vena cava, your aorta. Broken ribs can make breathing difficult. You may have the heart actually could be bruised, and by doing that, you can cause an irregular heartbeat. Large vessels from the heart can actually be torn and cause massive bleeding inside when that's unseen. So we got to make sure that we're always alert for changes in our vitals. Air can collect between the tissue and the chest wall, like that pneumothorax we talked about, and we could actually blood collect in that area as well, and that's called a hemothorax. So a pneumothorax is air outside of the lung inside the chest cavity. Hemothorax is the same thing, it's just blood instead of air. So as injuries to the chest, penetration can leave pressure gradient. So we can have actually, if there's a hole in the chest wall, when we breathe in, our lungs expand, and hopefully air is pulled in through our airway into our lungs. If we have any kind of penetration to the chest wall or any kind of open chest wound, then whenever we breathe in, that pressure gradient isn't there, and so therefore the lung may not expand and air may actually get sucked in through that external chest wound. And so it's called a sucking chest wound, and you'll cover it a little bit later. I posted a video on how to create occlusive dressings in order to treat that particular injury. I remember the abdomen has a lot of organs that require a lot of blood, so a lot of solid organs there that can be lacerated. Lots of internal bleeding can happen. Hollow organs such as the stomach and the intestines can be ruptured and leak gastric contents into the abdominal cavity, causing sepsis later on. You may have, well, just like we said, solid organs tear, hollow organs leak, and the rupture of large vessels can cause someone to become hypovolemic or go into hemorrhagic shock and never have a drop of blood hit the pavement outside, because it's all contained within a body cavity, but it's not within the vascular space, and so it's not circulating around, going and picking up oxygen and delivering that to the places it needs to go. Remember that in our management, our scene time, less than 10 minutes always. Anytime we have a critically injured patient, that is a patient who has sustained a significant mechanism of injury, they have a decreased level of consciousness, or there's any threat whatsoever to airway, breathing, or circulation. And also patients who are very young or very old with chronic illnesses. All these patients are considered high risk, but all trauma scenes are less than 10 minutes. We're going to select our destination. Here's the different criteria for level facilities. A level 1 trauma facility is where you would want to go most of the time. That has every aspect of trauma care. They have a trauma team on call 24 hours a day. A level 2 facility provides initial definitive care, but obviously you don't have the resources that you would have at a level 1. A level 3, they have advanced trauma life support, but basically what they do is they stabilize and ship out to a level 1 or a level 2, and then you have your level 4, which is basically your standard ER that does the best it can until somebody else gets there. Air Medical, or the Association of Air Medical Services and Medevac Foundation International, they list out the following criteria as a need for calling for a helicopter. You might have to call for a helicopter if there's an extended period of time that's going to require for extrication, or if the distance to a trauma center is more than like 20 to 25 miles. If the patient needs ALS, but there's no ALS ground unit available, that can get there within a reasonable time frame. And remember, these are their conditions for contacting or activating air medical to come and fly to your scene to pick up your patient. If traffic conditions or The availability of appropriate hospital, it's unlikely that the patient's going to get there in a reasonable amount of time, or if there are multiple trauma patients that, we don't want to overwhelm resources at a nearby trauma center. We might fly some to a farther away location, even though the location's farther away, then they can still get there in a reasonable amount of time. And obviously, with any kind of mass casualty incident or whatever, we might want to consider having air medical on standby so we can transport out multiple patients pretty rapidly. And trauma centers are categorized as adult or pediatric, but just because one is one and doesn't mean that they have to be both. We know that located nearest to us would be Wake Peds. We know that Wake's a trauma center, and they do have pediatric specific facilities. And then types of different transports. Once again, we got ground units, we got air units. Ground units are staffed by EMTs and paramedics, whereas air units are typically staffed by paramedics and nurses. And this is the algorithm for your transport and destination. You can go through and check your boxes. You can read this at your leisure. There's no sense in us reading through it right here at this time, but I would suggest definitely looking through the charts in this PowerPoint. That information would definitely come in handy in testing and when you're doing your practical exercise. And finally, in your management of your trauma patient, some special considerations. Remain calm. The first pulse you should always check is your own. You don't do anybody any good if you get excited, because when you get excited, then you miss things. So stay calm and complete an organized assessment. Do it in a comprehensive order, okay? Correct life-threatening injuries when you get to them immediately. Now, obviously, do no harm, but never hesitate to call ALS backup or medical control for guidance when you're treating your patient, because no two traumas are ever going to be the same. And so we learn cookie cutter skills, but what we have to do is we have to take those specific skills and apply them to a lot of different situations. And as long as we practice and reach a high level of proficiency, it's not hard to take those skills and apply them to multiple situations. So organized assessment, correct life-threatening injuries, and don't hesitate to control or contact med control or call for ALS.